have kind of suffered, okay? Back, prior to x-rays, prior to really blood tests, folks used to come up with the diagnosis, commit to the diagnosis, and then treat the diagnosis simply by the history and the physical, right? When you look at old movies of folks practicing medicine, they didn't have labs, they didn't have fancy scanners to tell them the answer. So the history and the physical is still the most important part to your physical exam. When you do the physical exam, there's going to be, especially from the cardiac standpoint, there's going to be some very subtle findings that require you to be doing this exam in the proper environment. So it's got to be quiet, it's got to be well lit. You have to have good equipment, so like your stethoscope's got to be well maintained and functioning properly, or else you may have some difficulties in appreciating those subtle findings. Even with all of those things, there may still be some subtle findings that you're not going to hear, you're not going to appreciate. And this is where kind of some of the new inventions in medicine are coming. You can kind of see in this picture here, this fancy stethoscope. It uses AI to help you with diagnosis. And what it can do is, it's like a 3-lead EKG, so you can kind of see what the lead 2 and help you diagnose some arrhythmias with it. But it also listens to the heart sounds. It can actually tell you and detect subtle murmurs to help you diagnose valvular disorders or diseases much earlier in the course of the patient's experience. It also allows you to turn up the volume of what you're hearing too, which is nice because if you are a little hard of hearing or it is a loud environment, you can change that volume and maybe you can appreciate what you're hearing. I'm not endorsing this stethoscope, but these are the new things kind of coming out there. This one, the stethoscope itself, if you get it on a discount, it's like maybe like $400, but it does have an annual fee to use the AI features of it. So subscription, right? And the DOW will not pay for your subscription. So that's out of your own pocket. So when you do a physical exam for the cardiac exam, similar to any other organ system you do, the tenets of inspection, palpation, auscultation play a role. And based on the physical exam, looking at all these different things, you can detect the different pathologies that are going on or could be going on and come up with your diagnosis. And we're going to walk through each one of these individually. So let's start with inspection. So the first thing you're going to do is just look at the chest configuration. The normal chest configuration is, it typically is wider than it is deep in about a 2-to-1 ratio. Okay? We're going to show some abnormal and why the abnormal is bad. But when you have a distortion to this chest configuration, or this normal chest configuration, it can have so many different impacts on the function of the heart. And it could be that the blood flow out of the heart or the blood flow into the heart is going to be disrupted. So your cardiac output is going to suffer. It's going to affect the 3 things that affect your stroke volume and your cardiac output, right? If you have an abnormal chest and your lungs can't expand with inspiration and then with exhalation go down, you're not getting that normal chest rise and fall. That's going to distort that venous return, and it's again going to affect the function of cardiac output of the heart. And this is just a couple of examples. You can see, okay, the top picture is what a normal chest configuration looked like, so that 2-to-1 ratio. But look at pectus excavate, so kind of digging in, right? You have your sternum is depressed and it goes in. Imagine what's going to happen when you have that obvious distortion of the chest. It's going to, one, either push the heart back, or it's going to shove it to the side, which is then going to affect the expansion of at least that lung, whether it's being distorted to the left or to the right. So that lung's not going to expand well. So that's going to have some cardio effects, but imagine also those pulmonary effects as well. The next one over is pectus carinatum. Carinatum meaning bird, carrion. And what happens is the sternum is actually displaced anteriorly. So now you almost have too much of a AP diameter, and now you have all this extra room for expansion, which seems great, but the body likes to fill spaces if there is space to be filled, right? So what can happen is actually your intestines will shove up into your chest too. So there is some distortion and some impacts that can happen with that. The next one is now that AP diameter is increased in like COPD in this barrel chest. And with COPD, you're going to have hyperinflation of the lungs, which is going to then press on the heart. And now the heart's not going to get that venous return like it should. It's not going to have that easy output either. So that's going to disrupt the function of the heart. And then if you have like a scoliosis and a twisting of the spine and such, you can imagine what that would do depending on how severe that scoliosis were to be and how that would affect the function of the heart. So let's continue. So we looked at the chest, now let's look at the skin itself. So lots of different things that you can visualize when you're doing the skin exam that help you see what exactly the status of perfusion of the skin, of those extremities is, as well as some other types of findings, like how is that blood flowing into the different extremities and how it's affecting the skin itself. When we talk about cyanosis, we're talking about like this bluish or this purple-blue kind of appearance to skin, to digits, to lips, to different parts of the body. And basically, this is an assessment of oxygenation of that area, whether it be there's just not enough oxygen in the blood itself, like in a pulmonary disease, or the blood is not getting to that region like it should. There's a blockage, there's something going on. And there's really two types to this. The peripheral we'll talk about first, which kind of think of this as the periphery. So your extremities, things far away from the torso are impacted with this. And when you see peripheral cyanosis, be thinking that something is interfering with the blood, the oxygenated blood, getting to that area. So that could be there's a blood clot. It could be that they have like a spasm of the artery, so that blood is not getting there. And we'll talk about specific conditions that do that in block 2. It could be that they are severely sick, they're septic, and now you're not perfusing. You don't have an adequate cardiac output to reach those extremities to provide the oxygen that they need for normal function. When I was deployed out to 5th Fleet or CENTCOM on the carrier, I went to our supply ship, and we were off the coast of Iran and Pakistan at the time, and went and saw a civilian mariner on our supply ship. And he had a history where his palm had been cut right there, and it knocked out the superficial palmar arch. So the radial supply of that arch was disrupted because of that trauma. Well, his fingers looked like these digits. They were cold. When I put pulse ox on it, it was 64% oxygen. My recommendation was get him into the carrier and fly him to Bahrain immediately so we could go see a vascular surgeon, because something was disrupting the flow of oxygen to his digits. Unfortunately, the medical team on board wanted to delay until they pulled him to Djibouti to get seen, because they were falsely reassured that he could move his fingers, there was function, so it must not be that bad, right? Well, where are the muscles that move your fingers? It's in your forearm, right? So you just have tendons that go out to pull this. So we were falsely reassured because he had motion, he had movement, he had function. It must not be that bad, but he had good perfusion to the forearm, but not to the hand. And unfortunately, I think he had to have an amputation of those digits because it had been going on for a week prior to me getting there, and then it took another week for him to get home and get evaluated by a vascular surgeon. So that's peripheral cyanosis. Central cyanosis, this is your trunk, this is your head, and thinking of the center of the body. And if you see this on a patient, be thinking that the problem is that there's an oxygenation of the blood. That's the problem, okay? So this could be somebody with severe pulmonary disease where you're not exchanging oxygen for carbon dioxide, right? It could also be congenital birth defects, and we're going to talk about some congenital birth defects later on in this block, and we'll show this. So we'll talk about those conditions. But if you see this in a baby immediately after birth, and I mean like a couple of minutes, that's normal. But as the baby is breathing high oxygen content air, you're getting that exchange of oxygen and carbon dioxide, then that central cyanosis will go away. So we'll talk more about this in pediatrics next semester. But central cyanosis is a oxygenation problem. If you see pallor, this is an anemia, or the most common cause of this is like an anemia problem. There's just not enough boxcars or hemoglobin to bring oxygen to that area. It's not that it's getting no oxygen. It's just there's just not a lot. There's not the blood itself, the volume of actual red blood cells getting to that area is just not high enough to actually give you the normal pinkish, reddish tinge that you see in conjunctiva. And because of that stress, you normally see a compensatory mechanism where the heart rate's going to go up because it's going to increase your cardiac output to try to get that oxygen circulating and getting it at least to the minimum requirement there to make up for that lack of oxygen carrying capacity. Then edema is an important thing. And you see this is pitting edema. So when you put your finger on that swelling, your fingerprint is going to stay in the skin at least for a period of time. Okay? So pitting edema, typically we think of as fluid overload from a heart failure thing. It could be a number of other things that you can kind of see at the bottom of this, to include hypothyroidism. But typically when you have one of these conditions, whether it be cardiac or metabolic, it affects the extremities equally. Okay, you have edema on both sides. If you see edema only on one side, then we're thinking of, especially if it's pitting, we're thinking of like there's a blood clot affecting the blood flow in and out of that leg on that side, whereas the blood flow to the other leg is fine. If you have somebody who has a true heart failure, true edema, it goes to the gravity-dependent areas. And that's important to know because if I have somebody who is walking around with this, yes, gravity-dependent areas is going to be to their feet, right? But let's say they're in the hospital bed, their feet are propped up. Where is the gravity-dependent area in that case? The buttock, the back. So you don't just look at the extremities and be like, oh yeah, you're getting better. No, you got to look at where the gravity-dependent areas are and check that. And you can actually do the same test, like in the lower back, in the sacral area, put your thumb in that swelling and see if it actually is pitting or not. So don't be falsely reassured if their legs are propped up and the swelling is going down. It could be that it's moving to other places. Clubbing. So this is a distortion of the nail bed. And this is a reaction to a chronic problem. This is not something that's going to happen acutely. This is something that's going to take time to develop this reaction. And we typically will see this in like chronic pulmonary diseases where you're just not getting that oxygenation like you should. So this might be like your COPD or your poorly controlled asthmatics, where it goes on for weeks, months even, when you see this distortion of the nail bed, where instead of having that kind of concave appearance that you have, it's more of this convex where it comes up and then it goes down there at the nail bed. So. And then we have jugular venous pulsations, which we'll spend some time on this to look at it. The first thing is, the thought is, when you're looking at the jugular venous pulsations, you're getting an idea of what is going on in the right atria. There are no valves between the internal jugular vein and the right atria. Unlike other veins where there are valves, there isn't one in that area. So you're getting kind of a direct correlation of the health of the right atria by looking at the jugular venous pulsation waves. And the way you do it is put the head of the bed about 30 to 45 degrees, have them kind of turn their head so they're looking to the left, and then taking a flashlight and watching that pulsation wave. And then when you see that the highest that it's going, you kind of mark that, and then you measure from the notch of the sternum to the manubrium, and then go up, measure that, and then add 5 centimeters, and that gives you your value. And what happens with that is I can then tell what is the average pressure in the right atrium. So normal is 6 to 8. We get a little wiggle room to 9. Anything more than 10, equal or larger than 10, is considered abnormal. And now you change that jugular venous pulsation, JVP, to jugular venous distension, or JVD. And that is the pathologic form of elevated pressure. And typically when you see jugular venous distension, so that abnormal pressure, usually we're thinking of things where there's a volume overload. There's too much fluid. The heart's not circulating that volume around like it should. And what's interesting is we actually can see this little pulsation wave, and the significance of these waves gives you an idea of what is going on in the right atria, and what is the overall health of the heart based on that. Now, are you going to be able to look at the jugular venous pulsation waves and you're going to be able to kind of see these things? Well, you can, but you're only really going to probably see those two spikes. But as far as the drops, the valleys, and those kind of things, that's going to be hard to determine or see. So we typically will rely on some kind of monitoring device that will tell us those pressures. But you'll see this kind of waveform with your jugular venous pulsation waves. So then you may be asking, well, what do each of these things mean? Well, remember, this is the right atria, so the pressure in the right atrium. So the right atrial pressure is greatest at the waveform A here, which is the peak of the atria squeezing, contracting, the atrial kick, right? So right before systole starts, where you're trying to get as much blood volume out of the atria and into the ventricle, you're going to get that squeeze, and that's where that pressure is going to be at its highest point, right? Well, that atria is going to start to relax, or it can't maintain that high pressure. It starts to drop. Then you get S1, so that's the closure of your tricuspid valve, because we're only concerned about the right with this, right? So you're going to get that closure of the tricuspid valve. Systole officially starts. That ventricle starts to squeeze. Well, that squeeze of ventricle is going to cause the pressure in the ventricle to go up. So it's going to cause the leaflets of that tricuspid valve to kind of balloon back into the atria a little bit, which is what gives us this C wave, but it's going to be limited. And then that pressure continues to drop into this X descent here, where now the atria is fully relaxed. It is willing to take on as much blood coming back to the heart through the inferior and the superior vena cavas and the coronary sinuses. And then you start to see, as that volume starts to accumulate, you start to see that pressure in the right atria start to increase. And it increases, increases, increases. The ventricle is finishing its job during systole, and you get that closure of the pulmonic valve, because we're only concerned again on the right side with this. So you get the closure of the pulmonic valve, which is your S2. That signals the start of diastole, and that, but you don't get an immediate opening of the tricuspid valve. There is a little delay of this distance here between the closure of the pulmonic valve and the opening of the tricuspid valve. So during that brief period of time, that pressure is continuing the increasing in the atria, the right atria, until that tricuspid valve finally opens, which occurs at the V wave, and then you get that sudden rush of blood volume going into the right ventricle, which brings you down into this Y descent before that pressure starts to increase, and then you get the atrial contracting again, and then starts to cycle all over again. So does that make sense? What each of those peaks, each of those waves, and each of those descents is kind of indicating? Well, what's important to know about this, and the reason we talk about this wave, is if I know what's going on with the different waves, I can actually diagnose the pathology that's present in the heart. And I'm not expecting you to memorize this right now, but as we talk about each of these pathologies, we're going to say, oh, the A wave is this, doing this, the Y descent is doing this. So you'll see, as we talk about the different pathologies, you'll see how that impacts this pulsation wave, and we'll understand why that's the case. The one thing I did want to point out is the absent A wave. So when you look at the jugular venous pulsation waves, you don't see an A wave. This is typical of atrial fibrillation. You're not getting that atrial kick. Remember, that A wave is that atrial kick trying to increase that pressure rapidly to try to get that volume of blood out of the atria and into that ventricle, right? So if I don't have that coordinated squeeze of the atria, I just have that quivering, I lose that A wave. So I don't get that squeeze, I don't get that contraction of the atria, and I don't get that sudden rise in pressure in the atria to cause that A wave. So it's the only one I may expect you to know for a test. Going back to the jugular venous pulsation wave, typically when you take a breath in, you're creating that negative pressure environment, so you're increasing that venous return going to the heart. In a normal functioning heart, you're going to see that jugular venous pulsation wave drop because that pressure, all that volume is going back to the heart, right? Being pulled out from all the other peripheries and getting sent to the heart in a normal functioning heart. However, did you have a question?
Yeah, that wave has nothing to do with the ECG, it's just the
Correct.
pressure in the atria at any given time during
Correct.
the
Yeah. Yeah, your EKG could be doing really anything. Now, there is going to be some overlap and some correlation between the two, but you don't get kind of lost with, okay, on the EKG, this is where the QRS is happening, this is where the T wave is. Don't kind of correlate those two, because there are pathologies where things are going to be a little different versus what's going on electroconductively. in the EKG and what's actually functionally happening.
How's that measured?
So the way this is measured is, and we'll talk a little bit about this tomorrow, but you actually will drop a set of lines, kind of called like a Swan-Ganz catheter. You'll drop that down through the IJ into the atria and into the other right heart structures. And you can monitor all of these pressures based on, I think there's like 4 or 5 different things that come into this big catheter that you put into the heart. And you can monitor all that. Did that answer your question? So in a normal heart, that jugular venous pulsation wave is going to drop when you take a breath in. However, there is going to be certain pathologies where if something is wrong with the ventricle, the right ventricle, you're not going to want to accommodate all that extra volume coming back to the heart when you take that breath in. So what's going to end up happening is you're going to have a backup of that blood going from the right ventricle that doesn't want to deal with it. It's going to go into the right atria or stay in the right atria, which then means it's going to, because all of the blood coming back from your legs and your arms is going to then have to go somewhere. So what it's going to do, it's going to go up into the internal jugular vein, and you're going to see that pulsation wave actually increase with inspiration. So you see Kussmaul's sign when there is something affecting the function of the right ventricle to where it doesn't want to take on all that extra volume, all that preload coming back during inspiration. So does that make sense? And we'll talk about a couple of conditions in actually this block that will show Kussmaul's sign. Another thing you can do is the hepatojugular reflux. And what this is, in situation where there is a volume overload, instead of the blood going up through the IJ and down into the abdomen or getting kind of stuck in the portal system, the portal venous system, I push on the liver, and what I'm doing is I'm trying to push all that volume out of the liver and back up to the heart, which in a normal functioning heart, it should be able to accommodate that extra volume. But if I have a diseased heart or I have an excessive volume present, the heart can't take on that extra volume, and what you'll see is then that blood is going up to the jugular venous system, and you'll see that pulsation wave go up by pressing on it. So that is the hepatojugular reflux. Push on the right up quadrant where the liver is located, and you see that JVP go up. Does that make sense? So let's move on then from the inspection phase, to the palpation phase of the cardiac exam. And there's a number of things that you're going to be able to test for with the palpation phase. So PMI, or point of maximal impulse, this is you kind of put in the heel of your hand. Typically, it's in the apex of the heart, in that 4th, 5th intercostal space, mid-clavicular line. Put it there, and that's where you should be feeling the heart beating. But sometimes what can happen is that can kind of get distorted depending on what's going on inside the heart. It can get distorted either to the left or to the right. So in like left ventricular hypertrophy, it's going to get distorted to the left. In right ventricular hypertrophy, it might get distorted to the right. Okay. The other thing is, normally this should only last about 2/3 of the systolic phase. Okay. But if there is a distortion, then it can indicate that there is some kind of pathology going on in the heart from this normal value. And you can see that we talked about left ventricular enlargement, it's distorted one side or the other. You can get this in situations like volume overload, where you have like an S3 auscultation event. you can get this hyperdynamic impulse where it may be over here 1 beat, and then it shifts a little bit to the next beat, and it just is kind of moving around on you. It's not consistent from beat to beat. If you have pressure overload, which is typically if you have an S4 on auscultation, typically this is indicative of like a left ventricular hypertrophy, and you get a sustained impulse. So now that squeeze, that palpation of that impulse is going to last longer than 2/3 of systole because it has so much pressure that it has to exert for an extended period of time to keep that valve open to get that blood circulating. It's going to have to squeeze longer in systole. So that's why you'll see that PMI kind of distorted. Then you can palpate thrills. Thrills is kind of like this buzzing or this vibratory sensation that you can actually palpate. And typically we'll see this in folks who have pretty severe valvular diseases where you can actually feel kind of that blood circulating around. One of the most common thrills that you can palpate is somebody who is hemodialysis dependent, and we have created a fistula in one of the peripheral arteries and veins for us to do the cannulation for hemodialysis. You can actually put your hand on it and you can feel that vibratory sensation because you're having high pressure blood from the artery getting attached directly to the vein, going through that superficial vein. So you can actually feel that thrill. A heave or a lift is a physical exam finding where you put the heel of your palm on the PMI basically, and what will happen is that heave, or because of that extra strength that has to be exerted to circulate blood out of the heart, you actually will feel that impulse actually kind of pushing your hand out of the way, just because of how strong that squeeze is. That is not a normal finding, but in somebody who has a number of different pathologies, you can actually have your hand kind of getting pushed out of the way when it contracts. And then we have the blood pressure, and then we also have feeling the pulse. So blood pressure measurements, yes, you use a blood pressure cuff. If you're going to use a manual, you also have a stethoscope to help you auscultate that pressure. And you should see symmetry from left to right, and you should also see symmetry of upper extremity and lower extremity. If you don't see that symmetry, then maybe something's going on that you need to investigate. So there should be symmetry left, right, up, down. Now the pulse pressure is factored in when you take your systolic blood pressure and you subtract your diastolic pressure. And the value normally is 30 to 40 millimeters of mercury. So that is a normal pulse pressure. But when it's increased, so now you're greater than 40, it could be indicative of something like aortic regurgitation, where you have this intense squeeze of the heart trying to get all this extra blood volume out, but because you have no integrity with the one-way valve of the aortic valve, all that blood starts flowing right back into the the left ventricle, and you bottom out your diastolic pressure. So now you're going to have a pulse pressure greater than 40. When you have a narrowed pulse pressure, where now your systolic is low, but your diastolic is maybe normal, but it's now less than 30, this could be indicative of severe dehydration. We just don't have that blood volume. It could be hemorrhage, severe hemorrhage. Those are a couple of different examples of things that could cause a narrowed pulse pressure. And then the pulses themselves, they have specific waveforms. Yeah, again, maybe difficult to actually palpate this, but if you had the use of monitors, you would see this on the monitor. So if you ever are in the ICU and they're on some of these invasive monitors like arterial lines and those types of things, you'll actually see these pulse waveforms. And if there is a distortion to that, it could tell you that something is going on in that patient's pulse. And then we have, of course, the auscultation, which is what we do for every one of our patients, right? This is what makes our patients think we're doing something for them when we listen to their heart. And you can do this in a number of different positions. Depending on the cardiac murmur that you're listening for, you may need to have the patient roll on their left side to be able to hear that murmur. But typically, we think of S1 and S2 as the normal heart sounds. But S3s may be normal in some folks. In the right population, it might be normal. But outside of that population, it's an abnormal heart sound. S4 is always abnormal. And then you also, of course, have the murmurs that are present. And you can actually get an idea of what's going on based on where you're hearing this murmur. We're going to go over this chart in a couple of slides and more in depth. You, of course, are going to use your stethoscope to auscultate, right? You've got the diaphragm side and you've got a bell. I know earlier in your education here, we taught you how you do like a light touch, and that's your bell with the stethoscope, right? And then you do more firm, and that's your diaphragm. That works for certain kinds of stethoscopes, so just be careful. That may not always be true. I was always taught that you had to flip the stethoscope over so that the smaller end was your bell, and then the larger end was your diaphragm. So when you get your own stethoscope, read the instructions to see if that the bell diaphragm thing actually works by using the same side. So just be careful about that. But why does that matter? And it's because the diaphragm tends to give you your high-pitched frequencies, your high-pitched sounds. So you want to make sure, if you're expecting to hear a high-pitched murmur or high-pitched heart sound, you want to use the diaphragm. But you may not, if you're using the diaphragm, you may not actually hear the low frequency stuff. And that's where the bell comes in, is that will give you those low frequency heart sounds, those low frequency murmurs that you may not appreciate if you just are using your diaphragm. So make sure you're doing your cardiac exam with both the diaphragm and the bell to make sure you're not missing anything. So when you're auscultating, the three things you've got to ask or answer or ask yourself if you hear something abnormal is, well, one, where's my stethoscope located? Two, which side am I using? Is it a high-pitched frequency thing and I'm using my diaphragm? Or is it a low frequency and I'm using my bell and I'm hearing this abnormal sound? And then the last question you're going to ask yourself is this occurring during systole or is this occurring during diastole? Because the answer to each one of those questions is going to lead you down a path to a completely different diagnosis. You could be hearing the same thing, but one's during systole and one's during diastole, completely different pathologies. And we're going to get a good hands-on experience using infrared stethoscopes with this during our lab, not next week, I think the week after. So we'll get a lot of practice with this in the lab. So going through the heart sounds, of course, starting off with normal, you got your S1s. So this is the lub part of the cardiac auscultation there, right? The lub, or S1, corresponds to the closure of your mitral, and your tricuspid valve. And it is best heard at the apex, because that mitral valve closing is going to be loudest at the apex, or the M, the mitral area of auscultation. I wish I could stop that. Get my little pencil. Okay. No? All right. And pause. There. So, when you hear the lub, this is the start of systole. Okay? So that's the significance of the S1. Now the S2 is now the closure of your aortic and your pulmonic valves. I think we've heard enough of that. So let me go back. So the dub is best heard in the second or third intercostal, left intercostal space. So your pulmonic auscultation site. Okay. This is high pitched, so this is going to be the diaphragm that's going to best appreciate this heart sound. And this represents, because this is the closure of the aortic and pulmonic valves, this is indicative of the start of diastole. Okay. The reason that you would think, okay, the aortic site would be the best area to hear it, right? The aorta valve is higher pressure than the pulmonic valve. But the reason that we say the pulmonic is the best auscultation site to appreciate S2 is because of this physiologic splitting of the S2, okay? And so what exactly is the physiologic splitting? So you heard a very distinct lub dub, but listen to this one. It's kind of hard to hear it in the overheads, but it goes ba-dub, ba-dub, ba-dub. It's not a very clear, kind of distinct dub. And it is much harder to hear it on this, which is why we do this infrared stethoscope lab, because it's so much easier to hear actually when you're listening with the stethoscope. So, more to follow. I guess you just have to hit the I believe button. That actually was splitting of S2. But what's significant of this physiologic splitting of the S2 is, and why you get this physiologic splitting, is when you take a deep breath in, you are increasing the pressure on the pulmonic side, because you have all this extra volume being brought up to the pulmonic side, or the right side of the heart. So what ends up happening is that P2, so that pulmonic closure, gets pushed over, and you kind of get a delayed closure, okay? Well, at the same time, on the left side, because you have created this negative thoracic pressure environment, the blood vessels, i.e. the pulmonary arteries and the pulmonary veins, want to hold on to this extra blood longer than normal. So what ends up happening is you're going to decrease that venous return, that pulmonary venous return, to the left side of the heart. So you're not going to have as high of a pressure on the left side. And what happens is that aortic valve gets closed kind of prematurely. Sorry, this way. So the arrow moves over to the left. So you get a kind of a premature closure of the aorta, the aortic valve. So you get premature closure of the aortic valve, you get a delayed closure of the pulmonic valve, and that causes that S2 to split. When I exhale, now I lose that positive or that negative pressure environment and create a positive pressure environment. Now that physiologic change is going to come, and that S2 is going to come together, and it's going to be very hard to distinguish between the two sides. Okay. And the significance of that is based on if that physiologic splitting is normal, then I okay, great, it's normal. But if that splitting of that S2 is abnormal, it can then point to different pathologies. And I'm not going to expect you to memorize this right now. I may, as we talk about pathology, say you're going to have a fixed splitting of the S2, and that's going to indicate a specific pathology, okay? But let's take a 10-minute break. We'll come back at 11 and finish up this lecture. So just remember, vanilla ice when it comes to listening to hard sounds. All right, so we talked about normal hard sounds. Let's start talking about abnormal hard sounds, which S3 can be a normal oscillatory finding in some folks, typically younger folks, less than 30. You can find this, but when you're thinking of it happening in like your older folks or that population where it doesn't really fit, then this is an abnormal heart sound, and usually is indicative of, pause this, get my pen. It's usually indicative of a volume overload. So in a congestive heart failure kind of picture, where you have too much blood volume and the pump itself is not pumping like it should, you can get this oscillatory finding. And you'll see this occurs soon or almost immediately after S2. So you may think that this is physiologic splitting of S2, right? Or maybe it is a fixed splitting S2, and it means some other kind of pathology. But the key difference between splitting of S2 and an S3 is S2 is high-pitched. So using the diaphragm of your stethoscope, S3 is a low-pitched sound. So this is best heard with your bell of your stethoscope. So that's one of the ways that you can help differentiate an S3 from a splitting S2. And this is known, also known as a ventricular gallop. So when you're recording your cardiac exam, you'll say no murmurs, rubs, or gallops. This is what you're talking about. Okay. So this is a ventricular gallop. Now compare this to your S4, which occurs in late diastole, almost right before the S1. And what you hear is, instead of a clear, kind of distinct lub, you're hearing balub, balub, balub. You may be wondering, well, why are you hearing that? Well, what's happening right before S1? So the closure of your tricuspid and your mitral valves. You're going to hear atrial kick. So what's happening in an S4, and what's causing this S4 is you're having that sudden increase, rise in pressure and flow of blood, but you have a ventricle that does not want to take on that extra volume. It's a stiff, it's non-compliant. So what's happening is that sudden rush of blood is running into that brick wall. And you're hearing that S4. So every time that atrial kick hits, you're getting that stiff, that blood running into that stiff, non-compliant ventricle, and you're getting that S4 sound. This is also a low-pitched frequency heart sound, so you're going to hear this with the bell of your stethoscope. Okay. Now, if you don't like, how that was presented, and you want to look at like more of a table kind of format showing the similarities and differences between S3s and S4s, here's this slide for you to hopefully clear up some of that confusion. So, other things you might hear on heart sounds that are abnormal is ejection clicks. Okay? Ejection clicks are high-pitched, So now we're going back to the diaphragm of your stethoscope, hearing this. And if it occurs early in systole, it means something different. Sorry. Back, okay. Sorry. There we go. Now, if you have it occurring in early systole, then you're thinking of this is because of a stenotic valve. So this is a stiff valve that doesn't want to move. It doesn't want to open. You're going to hear this early systolic. And the valves that should be opening in systole are going to be your aortic and your pulmonic valves. So this is aortic stenosis and pulmonic stenosis is when you hear these early systolic clicks. If you hear it in mid-systole, the aortic and pulmonic valve should already be open, and a mid-systolic ejection sound is typically a mitral valve prolapse, which we'll talk about mitral valve prolapse at the beginning of block 3 in more detail. But what happens is that valve kind of billows back into the atria as that pressure in the ventricle increases, and it could open. And then it gives you that mid-systolic click. Okay. Now the other heart sound that's abnormal, so ejection clicks are systolic murmurs or systolic sounds. A diastolic sound is called an opening snap. So opening snaps are diastolic. They are high-pitched, so diaphragm of the stethoscope. And typically, we are thinking again of an opening problem with the valve. And typically, you'll see this in mitral stenosis, because the mitral valve is trying to open in diastole to allow blood flowing from the left atria into the left ventricle. Okay. And then again, this is just kind of a table format to kind of compare all of those heart sounds that we heard. Okay. So now to kind of tie this together, this is probably one of the most important slides you'll get in all of cardiology, because if you can understand this and you can understand the abnormal pathologies, what's happening to this chart, everything will make sense. The pathologies will make sense. So we're going to spend some time on this. So this chart compares what is going on when you auscultate. So here's your S1, S2, S3. It's going to compare your EKG. It's going to compare, now we're only dealing with the left, but you could say that this also is going on in the right, just the difference is going to be which valves are closing and opening, and also just the degree of pressure changes are going to be a little less on the right side than normal. But this one, it deals with the left side. So you're going to see the ventricular volume, so the amount of blood in the ventricle, what's changing over time, the different phases of the cardiac cycle. The blue line is your ventricular pressure. So what's the pressure doing in the left ventricle? This line here, this gray line here is your left atrial pressure. And then the top gray line is your aortic pressure. Okay? So we're going to start with S1. So you're going to hear it. S1 is the start of systole, right? Well, systole correlates with the mitral valve closing, or the S1 correlates with the mitral valve closing. And when you correlate that with your EKG, you're having a ventricular squeeze is happening. So you already are having that depolarizing event occurring in the ventricle. So that's your QRS. So your QRS is happening at the time of your mitral valve closing. Well, the pressure in the ventricle when that mitral valve closes is basically just above the atrial pressure. That's why you get that closure of the mitral valve. Well, now you have that ventricle still squeezing, the pressure is increasing, but the aortic valve has not opened yet. So that pressure rapidly increases, but the volume doesn't really change because you're not having blood coming from the atria into the ventricle because you've already had that mitral valve close. Well, as that pressure in the ventricle continues to climb, as that ventricle is squeezing, you now get to the point where it equals or just gets above the aortic pressure, just above that aortic pressure, and now you get that aortic valve to open. So you get that opening, and now you start to lose volume of blood in the left ventricle because it is getting sent out of the left ventricle and into the aorta and getting distributed to the peripheral arterial system, right? But you still are squeezing, you can still squeeze, the ventricle has not completed its squeeze, so that pressure is going to continue to rise, and you can see it maintains that level where it is still above the pressure in the aorta. And that's important because maintaining that difference between the pressure in the aorta and the pressure that the ventricle has is what keeps that aortic valve open. But as the systole continues, you start to lose more and more volume in that left ventricle to the point where now you have the complete depolarization of the ventricular tissue, and now you start to have repolarization. So your T wave starts to come in, and you start getting relaxing of the ventricle, the myocytes of the ventricle, and now that pressure starts to drop. Well, as soon as that pressure in the ventricle drops below the pressure in the aorta, you now have the aortic valve closed, which is S2. Now you have this isovolumetric relaxation of the ventricle, so the pressure in the ventricle is going to drop, but because that mitral valve is still closed and you're not having blood coming from the atria into the ventricle, that volume in the ventricle stays the same until you reach that point where now that pressure of the atria exceeds the pressure of the ventricle, and now that mitral valve opens. And when that opening occurs, now you start to get that rise in the volume of blood in the ventricle. The pressure on the atria stays just above the pressure in the ventricle, so you're still getting that flow of blood coming from the atria and into the ventricle. And you start to see that flow of blood starts to kind of peter off, and then the P wave happens. So you get that atrial kick, right? And that atrial kick is going to cause a sudden increase in pressure of the atria, which is going to increase that sudden flow of blood volume from the atria into the ventricle, until it gets to the point where now that pressure in the ventricle exceeds that of the atria, and then you start systole all over again, and the cardiac cycle starts. So does that make sense? Probably going to have to spend time on this to make this make sense to you, but this is what's happening in the normal heart that allows blood to enter the heart, go from the atria into the ventricle, and then out of the ventricle and into the systemic arterial system. And any kind of deviation of this physiology leads to pathology. Okay? So it's pretty remarkable how tightly regulated this system is, and how just one little thing different can lead to the cardiac diseases that we're going to study this semester. So let's go on. We talked about abnormal heart sounds. Let's talk about now heart murmurs. Think of a murmur as a flow problem, where it's caught, that flow, that turbulence inflow leads to sounds that shouldn't be there. And you can get this typically when you have abnormal blood flow flowing across a cardiac structure. So you have too much volume flowing across a normal valve. You can get a flow murmur. you can get a normal blood flow that goes across an abnormal. So you get a normal blood flow going across an abnormal cardiac structure. So this is, you have a valvular disease, and that blood is just flowing across that valvular disease that's causing a turbulence in that flow, and it creates that murmur. And then the third situation that you can get a murmur is when you have abnormal shunting of blood, where this is, it's going from like from the left side of the heart to the right side of the heart, or vice versa, kind of depending on what's going on. And think of like congenital heart diseases when you think of this cause of murmurs. And we're going to talk about congenital heart diseases during this block. But when you're talking about a murmur, there's a lot of descriptors that kind of go into describing this murmur, so that based on what you answer, how you describe this murmur can lead folks, especially experts, to come up with a diagnosis of that murmur, okay? So what we typically will say is, okay, timing and duration. So when is it occurring in the cardiac cycle? Systole or diastole? What's the intensity? What's the pitch quality, configuration, location, radiation response? So we're going to go through all of those descriptors. So when we talk about timing and duration, this is just simply systole versus diastole versus holosystolic, or a continuous, meaning it goes through both systole and diastole. So that is a continuous murmur, as it goes through systole and diastole. Now the location, this is going to be important, because just simply knowing where you're listening and what phase of the cardiac cycle you're hearing this murmur can actually tell you what the valvular disease actually is that you're hearing. And this is one of the most highly tested subjects for cardiology, and not only on your pack rat, but also on your pants. So you could probably remember 11% of your pants is cardiology, right? Probably a good portion of that is actually just on this slide. So if you know this slide, you can get a good portion of your questions right. And this seems pretty intimidating. I was always intimidated when I was trying to determine what the murmur was that I was hearing, but it really is actually pretty simple. And it comes down to, when you look at the aortic auscultation site and the pulmonic auscultation site, you only hear systolic murmurs. So what are those valves doing during systole? They're open. So a murmur that you hear during opening problems of the valve opening are known as stenosis or stenotic. Okay? So if the valve should be opening during that phase, it is a stenosis. If it should be closed during that cardiac phase, then that is known as a regurgitation murmur. Okay? So you're having an abnormal flow across a valve that should be closed. That is regurgitation. Okay? So the aortic and the pulmonic auscultation sites, you only hear systolic murmurs, and so you have stenotic valvular diseases in those areas. So if you're listening to the aortic auscultation site and you hear a systolic murmur, then you have aortic stenosis. If you're listening in the pulmonic site and it's during systole, then this is a pulmonic stenosis. Okay? When I look at, we'll come back to Herb's point, but when I look at the tricuspid area, now you can see that you have holosystolic and diastolic murmurs. Okay? So you do have systole, but the version of the systolic murmur that you get is actually holosystolic. So the full duration of systole, you're hearing this murmur. And what should the tricuspid valve be doing during systole? Should be closed, right? So if that valve should be closed during that phase of the cardiac cycle, that is a regurgitation murmur. So this is, so if you have a holosystolic murmur in the tricuspid area, it is tricuspid regurgitation. Now there is an extra little murmur in there that we're going to talk about during the the congenital heart disease lecture, but just think of holosystolic tricuspid as a tricuspid regurgitation, okay? Now, switch the phase of the cardiac cycle, and I'm listening to the tricuspid area, and now I hear a diastolic murmur in the tricuspid auscultation site. That valve should be opening, right, during diastole, and I hear that murmur. That tells me that there is tricuspid stenosis, okay? When I look at the mitral area, kind of think of it as the same thing. So instead of now tricuspid regurgitation and tricuspid stenosis, now you're thinking mitral regurgitation for a holosystolic murmur, and a diastolic murmur is mitral stenosis. And then there is a caveat with this mitral valve prolapse where now you're having a systolic murmur. But just listening to those areas, those 4 sites, you can kind of get the idea of what's going on with the heart valve, and if it's systole or diastole, it can tell you what exactly the murmur is. But kind of going back now to the left sternal border, or Erb's point, if you recall, we only talked about systolic murmurs in the aortic and pulmonic site, right? But what about the diastolic version of those valvular diseases? So the regurgitation murmurs. That's where you're going to go to Erb's point. And because those are diastolic, you're going to hear, of course, this during the diastole phase, and these are going to be diastolic murmurs. And the reason that you are hearing this at this site is what's the direction of blood flow in an aortic or pulmonic regurgitation? It's down back into the heart, right? So you're hitting that septum, which is what Erb's point is kind of overlying. So that is why you hear these murmurs, these diastolic murmurs, at Erb's point as opposed to at those particular valvular auscultation sites, okay? So that's the location part. There are 2 murmurs where that sound does radiate somewhere else. So mitral regurg, it actually radiates up into the left axilla. And the reason for that is that mitral regurg, that blood flow is going from the left ventricle and into the left atria, right? Well, remember how your heart is kind of twisted and tilted back. So now that path of a mitral regurg is actually going to the left axilla. So that's why if you have mitral regurg, it radiates to the left axilla. Now, aortic stenosis radiates up into the carotid. And the reason for that is that stenotic valve is going to create a turbulent flow of blood as it goes out of the heart and up through the aortic arch and up into the carotid arteries, right? So where is that turbulent flow going? It's going up into the carotids. So that's why you get that radiation of that murmur going up to the carotids in aortic stenosis. Does that make sense? What you got?
So since it's pushed up the axilla, like if we're trying to determine that, like where exactly in the axilla are we trying to like that?
Yeah, so it's going to be just kind of right in this area here in the axilla. And you're going to have them hold their breath because you're going to hear them breathing. And that breathing is probably going to overwhelm that murmur. So they're going to have to hold their breath while you're auscultating that. But yeah, kind of like in the mid-axillary line is where you would listen for that radiation. So, any other questions? And again, we'll get a little more hands-on experience with this during the lab when we use the infrared stethoscopes. So moving on kind of to the descriptors of murmurs that we use. Then we talk about the intensity and the grading of those murmurs. And you can see systolic murmurs are graded from 1 to 6, and depending on which grade you give, that murmur is communicating something. You can't just say, oh yeah, it sounded pretty loud, it must be a 6. No, that 6 actually means something. It says, I'm sitting next to this person and I hear their murmur without a stethoscope. I'm just sitting next to them and you hear it. Diastolic murmurs only go from 1 to 4. So you don't have that 1 to 6 like you do in systolic. So don't ever say, I have a 5 out of 6 diastolic murmur, because there is no 5 out of 6. It's only 1 to 4 for diastolic. Okay? Now, other things, so pitch is basically what is that frequency? Is it high frequency or low frequency? That's where we got like the diaphragm of the stethoscope or the bell of the stethoscope that helps you hear those things. Quality is kind of like, what does that sound like? Is it harsh? Is it rumbling? Is it blowing? There is some descriptors that go into the quality of the murmur. And then there's the configuration or the shape of this. And what this is what is that intensity of that murmur doing over time? Is it getting louder and softer? Is it getting louder and it just stops? Or is it stays the same during the whole phase? And so you can get like this crescendo where it gets louder, 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 and then stops. You get this crescendo where it gets louder, 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 and then a decrescendo, which is gets softer. And then you can get it where it stays the whole same, or holosystolic, pansystolic, where there is just this, it's steady the whole time. So when we kind of really tackle the valvular diseases in block 3, you'll see kind of the importance of how we use some of these descriptors in the intensity to give us an idea of what's going on with that valvular disease. Now, what is this going to sound like? What are all these different murmurs going to sound like? So let me put the pen off. So this is an early systolic murmur. This kind of shows you what that configuration of that murmur should sound like to you. So this is like a mitral regurgitation murmur, is what it's supposed to indicate. This is a mid-systolic murmur. What's kind of the difference between this is you get a distinct lub, or that S1. Unlike the last one where it kind of is like a whoosh. Again, we'll hear these with the infrared stethoscope, and it is a lot easier to kind of see these subtle differences between these murmurs. This is a late systolic murmur, such as like what you see with mitral valve prolapse. This one, you're getting the S2 is kind of obscured a little bit. You're not getting that distinct dump sound. And then this is a holosystolic. You're not getting a distinct S1, it's obscured, but you also are not getting a distinct S2 either. It's obscured as well. And then here's what a diastolic sounds like. This is what you would see with like mitral stenosis. So. Now, you may be asking, how the heck are you going to test us this? I am not going to give you auditory. I'm not going to give you auditory audio sounds, and you have to determine. I will describe the murmur that you hear. Okay. So, yes. Now, when you're actually taking care of real patients, they are not going to describe their murmur for you. You are going to have to hear it and describe it yourself. So, there's a test on the test. And there's a test in real life, unfortunately. So those murmurs kind of sound similar still, right? So how in real life could we help ourselves actually come up with these diagnoses? And it comes down to doing these special maneuvers or these dynamic maneuvers that help us with dynamic auscultation. And basically what I am doing with dynamic auscultation is I'm having them alter preload or alter afterload or both, and it's going to change how that murmur sounds based on preload or afterload being changed. And we'll kind of go through what we would expect to happen with the different types of dynamic maneuvers that you can do. One of the things we've already talked about was inspiration and expiration, right? That is a dynamic auscultation. They really just are doing it already on their own. But that is a dynamic maneuver. So inspiration. So we're increasing that preload, that venous return, right? So we're increasing that preload. And what usually will happen is right-sided heart murmurs usually get louder. So if I'm like, oh, I don't know if this is the right or if this is the left, let me have them take a deep breath in. If it gets louder, great, it's a right-sided murmur. If it doesn't get louder, it gets softer, then I know it's a left-sided murmur, okay? So that's what inspiration does. So we increase preload. Another thing that we could do is have them stand up. So what's going to happen is standing up, gravity is going to work against that venous return. So what's going to end up happening is they're going to have a drop in their preload. They're going to have that drop in venous return. And now you can get the intensity of like mitral valve prolapse or hypertrophic obstructive cardiomyopathy. Those murmurs are going to get louder. And we're going to talk about why in block 3 that you see that get louder. Valsalva. So if you're not like a diver or an aviator, have them take a deep breath in, close their mouth, plug their nose, and blow hard. What you're going to do is you're going to get an initial increase in your afterload, which then is going to drop off. So you get an initial increase in afterload, and then it comes down, but you're going to have an increase in their venous return, so that preload. And what's going to happen is this is going to make mitral valve prolapse and hypertrophic obstructive cardiomyopathy get louder. So kind of similar to what we just talked about with standing. When we have them squat, so now I am forcing blood out of my lower extremity, and I'm trying to get it return, or it's going to increase that return to the heart. So I'm going to increase my preload, and now you see it also increases your vascular resistance because with that squatting, you're bending those arteries in the legs, so you're not going to have a free flow of blood down to those arteries. You're going to have to work a little harder, so you're going to increase that afterload. And so what you see is the opposite, where now that murmur of mitral valve prolapse and hypertrophic cardiomyopathy actually decreases. And again, we'll talk about why in block 3. And then you have the asymmetric exercises where I just have them grip something really hard. And what you're doing with this one is I'm increasing my afterload, and it makes murmurs of like mitral regurg, and aortic regurg, and mitral stenosis louder, and it decreases the sound or the intensity of aortic stenosis and hypertrophic cardiomyopathy. It makes those softer. So those are our dynamic maneuvers, our dynamic auscultation maneuvers that we can do to help us distinguish these murmurs from each other. Now, if again you like the table format, here's one for you to kind of show you what dynamic maneuver you would do and what the expected outcome would be depending on what the pathology is that you're trying to elicit. So, questions? Okay. Tomorrow will be our last review It's only about 50-something slides, so I'll probably need maybe an hour, hour 10 at most. So I'll see you all at 8 o'clock tomorrow morning.